Hello, welcome to part 5 of the Interceptive orthodontic module. Today we are going to address the posterior crossbites, and we are going to discuss the bilateral crossbites, the unilateral crossbites. Are they functional or non-functional? We're also going to address the use of expansion in patients who do not present posterior crossbites. What is the management of a crossbite? The first and important aspect is to do a proper diagnosis. Crossbites sometimes present themselves as looking the same into the mouth, but once you do the proper testing and data collection, you'll find that their etiology is vastly different. Very important to do a proper diagnosis. Do not jump to treatment immediately. The timing of the correction is also very important. The correction has been shown to be more favorable at a younger age. You obviously want to obtain a complete orthodontic record, including a cephalometric radiograph, to ensure that the bony components of the craniofacial complex are in the proper position and that the crossbite is only a transverse problem. And obviously, you need to explain the benefits of correction to the parents, because many times, especially for a posterior crossbite, the parents are not aware of the problem. Let's look at transverse deficiency now. And Dr. Profit has noted in his 1990 article that 30% of adults present with maxillary transverse discrepancy, meaning over a third of the population could have benefited from a maxillary expansion procedure when they were younger. It's a huge number. What is the etiology of the crossbite? There is a lack of development of the whole maxilla. It could be genetic, or it could be also sometimes caused by lack of function. The whole upper jaw does not develop normally. Sometimes you have also a lack of development of the dental-alveolar complex, meaning the dentition should erupt wider, especially the upper dentition, but for all sorts of reasons doesn't, and you end up with a crossbite. This usually explains the functional crossbite. Sometimes you have habits that do not allow the upper jaw to develop normally. Obviously, in the past 10 to 20 years, we have looked at mouth breathing or sleep apnea as one of the causes of a narrow upper jaw, which may end up causing a posterior crossbite. A poor tongue posture could also be associated with a posterior crossbite. So all these etiologies of functional origin or genetic origin must be determined before you treat the patient. The transverse discrepancy can be present in any type of malocclusion. A lot of class 2 division ones have in centric occlusion present a normal occlusion, or actually a normal transverse dimension, but when you bring them forward into a class 1, you'll notice that the transverse discrepancy will become apparent. Please refer to Dr. McNamara article on this topic because he explains it very well. Refer to the reference sub-module in this module for online. The class 3s have exactly the same issues because a lot of these class 3s also present an hypoplastic maxilla, not just a hyperplastic mandible. The transverse dimension of the maxilla is affected. Here we can see that this patient presents a posterior crossbite on the left side of the maxilla and mandible, starts distal of the central incisor, and you can see also that the teeth are lingually positioned, but there are also a lack of development in the width of the maxilla. So I would argue this case is skeletal in etiology, but has also a dental alveolar component. Posterior crossbite can basically be of two origins, or can manifest themselves in two vastly different ways. They can be functional or they can be non-functional. A non-functional crossbite usually refers to a true asymmetry either of the maxilla or the mandible. The best example of a true asymmetry is the cleft lip and palate patient who presents with a maxilla that is not properly developed on one side, is asymmetric, and results in a non-functional posterior crossbite. You also have bilateral posterior crossbite that will not be actually addressed in this lecture. Because the crossbite is a bilateral, it doesn't have a functional origin. It's usually caused by a hypoplastic maxilla. It can also be caused by a dental alveolar problem, but usually these crossbites are associated with skeletal malocclusions and are difficult to treat, so we will not address these problems in this lecture. The one we want to address now is the functional posterior crossbite, where the posterior teeth, as is in this example, are in crossbite, as you can see. One of the main etiology and one of the main signs that the functional posterior crossbite is of functional origin is the midline deviation, as you can see shown by this blue arrow, where the lower midline, and it's the lower mandibular midline, is actually shifted to the left in relation to the upper maxillary midline in centric occlusion. You can also, it's not only a class 1 problem, it can be class 2, it can be class 3, it doesn't really matter. So please make sure you perform the facial analysis to look at the, as we can see here, the reference midline, the mandibular midline. Make sure that you are going to identify any deviation at the chin point to see if the patient presents with a posterior crossbite that has a potential to be functional. You look at the general symmetry of the patient, look at the midlines, facial, mandibular. We've seen that in module 1. You should do this for every patient you examine, regardless of the presence or not of a crossbite. So from this patient, which is vastly different, you can see she's a 7-year-old patient and presents, and that's what I use this patient, and I think that she's already in the module 1. It's an unusual patient in the sense that if you look at the reference midline, you can see that the upper maxillary midline is deviated. So be very careful. Do not take the maxillary midline as the reference midline, and that's why I use this patient as an example. You see the midline is deviated to the right. The lower midline, the mandibular midline, is actually deviated to the left by almost a whole tooth in relation to the upper maxillary midline. Maxillary midline is deviated to the right. The upper face is actually symmetrical and doesn't present any problems. So we use the arrows rule for the determination of crossbites. In this case, there's a deviation of the midline towards the right of the patient. Usually the problem will be located in the direction of the arrow. What are the exceptions? The most frequent exception is a supernumerary tooth that is actually shifting the midline the other way. But normally, in the vast majority of cases, if you use the arrows rule, when there is a midline deviation, you'll find the problem in the direction of the arrow. As I showed before, this patient presents actually a crossbite on the right that's pretty severe and an edge-to-edge occlusion on the left side. And you can see that in this case, there is no deviation of the midline. The midline deviation is always present when you have a posterior functional crossbite. So what is the difference between functional and non-functional? The best thing to do if you want to assess the presence of a posterior functional crossbite is, first of all, ask the patient to bite into centric occlusion, meaning maximum interdigitation, as shown in this picture. Patient presents a fairly wide diastema. This is the maximum midline, which actually fits with the reference midline, and this is the lower mandibular midline. So this patient, despite the fact that she has generalized spacing, still presents a crossbite on the left side. You can see the midline deviation. You can use the arrows rule. So what happens in a functional crossbite, the crossbite is present in centric occlusion. The concept is, if you do a bimanual manipulation of the mandible, the Dawson way, meaning you are going to take the occlusion, the dental occlusion, out of the equation. So you just use a bimanual manipulation of the mandible, and you are going to sit the condyles in their rest position, where they are going to present only a rotation or hinge movement. You remove all translation of the condyles. Then what happens, you will have a cusp-to-cusp relationship in centric relation. Let me demonstrate. So that's centric relation. So this patient now is actually being manipulated into a position where the condyles are sitting into the proper position in the glenoid fossa, and she's been asked to just stop at the first tooth contact. In this case, she stopped right here. There is a bit of a slide because when we took the picture, the patient moved a little bit, but this was the first tooth. There was an absolutely tip-to-tip contact in centric relation, and you can now see that the midlines are fully aligned, which means that the right side of the maxilla and the right side and the left side of the maxilla are of same size. The lower jaw is fully symmetrical, so the problem of this crossbite is not one of a difference in size from one side to the other. It's more caused by a interference in the occlusion that is causing the shift of the mandible, in this case, to the left. So the etiology of the functional crossbite could be an asymmetry. They are fairly rare, but it could be present. Normally, there is a lack of transverse development of the maxilla. That's the most common etiology of functional posterior crossbite. Sometimes you will also have an overdevelopment of the mandible, especially in class 3 cases, which become a whole lot more difficult to treat because it's difficult to reduce the size of the dental arch in the mandible if it's overdeveloped. So the arch shape, let's have a look at arch shape now. You can see that this patient presents a posterior crossbite. Right now we don't know if it's functional or not, but take my word for it, it is. There is a midline deviation. The crossbite starts at the canine all the way to the first molar. Patient is in mixed dentition, as you can see, so she's about 8 years old. There is also a problem with a missing upper right lateral incisor. So as you can see now, what you need to understand is if you look at the arches, they are symmetrical or almost symmetrical, as you can see here, and what you want is normally the arrow here and the arrow here should be of same dimension, because the lingual cusp of this molar has to fit into the central groove right here, and this one fits here, and the upper canine should be over this tooth, and this one should be over this tooth. So in this case you can see that there is a discrepancy in size between the lower intermolar distance in relation to the upper molar distance, and the intercanine distance is almost identical, which guarantees an interference in the occlusion, which in this case ends up in a posterior crossbite. So as I said, most common etiology of a functional crossbite, the maxilla is slightly narrower than the mandible, then you have a cusp-to-cusp occlusion in centric relation when the mandibular condyles are seated in the glenoid fossa. The mandible is slightly larger than the normally developed maxilla. So that's the two main ones. This is the most common one. This is the one we address most often, and that's the one that has the better results.